Hello, and welcome to today's webcast, Know Your Disease, Psoriatic Arthritis. My name is Bev Bromfield, and I'll be your moderator for today's presentation. Before we start, I'd like to go over a few items so you know how to participate in today's event. We've taken a screenshot of the attendee interface. You should see something that looks like this on your computer desktop in the upper right corner. You've joined this presentation using your computer speaker system by default. This means if you hear music through your computer, you should be able to hear the presentation. If you prefer to join over the telephone, select Use Telephone in the audio pane and the dial-in information will be displayed. You'll have the opportunity to submit questions to today's presenter by typing into the questions pane on the control panel. You can send your questions in at any time during the presentation. We'll collect these and address as many as possible during the Q&A session with our speaker, rheumatologist Dr. Arthur Mandelin. Before I provide information about the foundation, I'd like to acknowledge and thank our sponsors, AbbVie, Amgen, Bristol-Myers Squibb, Lilly, Novartis, and Pfizer for their support of today's webinar. Since some of you may be new to the foundation, here's a little background about who we are, our mission, and what we do. The National Psoriasis Foundation launched a new strategic plan in 2019, which drives everything we do as an organization. To achieve our mission, the following goals were identified: lead collaborative and transformational research in psoriatic disease, improve health outcomes by increasing the lifespan and health of individuals living with psoriatic disease, secure resources necessary to achieve our mission-related goals. By attending today's program, you've already taken a step towards expanding your knowledge about psoriasis and psoriatic arthritis, moving towards a better understanding of what it means to live with psoriatic disease. If you have psoriatic disease, you can help accelerate efforts towards a cure and a greater understanding of the disease by participating in the NPF Corona National Psoriasis Patient Registry, which is the largest independent observational registry of psoriasis patients in the U.S. This registry represents a network of dermatology clinics that collect and study patient health information, allowing researchers to compare the safety and efficacy of psoriasis treatments, better understand conditions that are related to psoriasis, and explore the history of the disease. You can share your experience with researchers about what it means to live with psoriasis and psoriatic arthritis by participating in Citizen Scientist. Answer questions and view your data along with over 4,000 participants. Data is used to help researchers gain a better understanding of the disease. To learn more and participate, visit the websites listed on the screen. We continue to improve health outcomes through our Patient Navigation Center, the world's first personalized support center for people impacted by psoriatic disease. The Foundation's Patient Navigation Center is available to help you find physicians, treatment information, navigate insurance issues, access support through our one-to-one program, and more. Contact us at 1-800-723-9166 or visit psoriasis.org/navigation center. To achieve the Foundation's goals as mentioned, please support our mission through donations or by participating in virtual Team NPF events such as Stamp Out Psoriasis or cycle events. You can learn more at psoriasis.org/donate or teamnpf.org. Now I'd like to introduce you to our speaker, rheumatologist Dr. Arthur Mandelin. Dr. Mandelin is an associate professor of medicine at Northwestern University, Feinberg School of Medicine, in the Department of Medicine, Division of Rheumatology in Chicago. Dr. Mandelin's clinical interests include psoriatic arthritis, rheumatoid arthritis, gout, ankylosing spondylitis, Sjogren's syndrome, joint injections, and interventional ultrasound. Dr. Mandelin is also actively involved in various clinical trials exploring current and upcoming treatment options and has extensive knowledge of musculoskeletal screening for arthritic diseases with a special interest in musculoskeletal ultrasonography. Dr. Mandelin is a member of the National Psoriasis Foundation's Medical Board and a President's Council member, which represents an elite group of healthcare providers who are committed to the mission of the foundation and finding a cure for psoriatic diseases. As a member of the Medical Board, he served on a consensus panel for the development of practice guidelines, which you'll learn more about today. It is my honor to welcome Dr. Arthur Mandelin, who will present Know Your Disease, Psoriatic Arthritis. Please welcome Dr. Mandelin.
Thank you very much. Thanks to the National Psoriasis Foundation for inviting me to speak to you this evening, and thanks for taking some time out of your busy day to learn this information. I have a couple of disclosures. I serve as a consultant for CVS Caremark. I'm on speakers bureaus for these pharmaceutical companies who are listed on this slide, and I'm a speaker and course director for the American Medical Forum, which provides physicians with the continuing medical education credits they need to renew their licensure. So what we're going to learn today are, we have 5 items on our agenda. We're going to learn about psoriatic arthritis, what it is, why inflammation plays a role in the development of that disease. We're going to discuss some of the symptoms and the features of the joint involvement of psoriatic arthritis. We're going to speak briefly about how the disease is diagnosed. We're going to talk about some of the treatment options on a very overview sort of level. Also, we're going to discuss why it's important to diagnose patients early and why we should be treating them to a specific goal, which can guide our therapy and improve outcomes. And lastly, we're going to cover a couple of resources that can help patients gain a better understanding of their disease and the treatment options which are available for it. About 1 of every 3 people who have skin psoriasis, or 30%, develop psoriatic arthritis at some time in their lifetime, usually between the ages of 30 and 50, and the disease does not discriminate between men and women, affecting both genders approximately equally. Most patients with psoriatic arthritis, somewhere between 80 and 90%, have their skin manifestations show up first, with the joint manifestations happening later. But this is not always the case. There are some in whom the skin and the joints become affected at the same time, and there are some for whom the joints are affected first and the skin disease only develops later. There are a number of comorbidities that are important. Among them are fibromyalgia or other chronic pain syndromes. Nearly 40% of people with psoriatic arthritis suffer with chronic pain. And one of the difficulties, and we'll understand in a few minutes why this is a difficulty, one of the difficulties with psoriatic arthritis is that it can take up to 4 years or sometimes more for a patient who has joint pain to be correctly diagnosed with psoriatic arthritis. That's an important problem, and it's one that the National Psoriasis Foundation is working on with quite a bit of vigor to try to improve prompt diagnosis, because that can help improve the quality of life and reduce permanent joint damage and disability in these patients. And we'll discuss very briefly at least one of the ways in which the NPF is helping with this effort. So to begin with, what is psoriatic arthritis? Skin psoriasis and its companion disease, psoriatic arthritis, are not contagious. They are immune-mediated diseases where the immune system has gone awry and is overactive, causing excess inflammation in the body. We wish we understood why this happens, but in fact we don't. Somehow the immune system is becoming dysregulated, and its natural, beneficial, adaptive response to go into overdrive and help you fight off invaders continues in overdrive in some patients and becomes a chronic problem where that constant state of alarm in the immune system is actually damaging to the body from being constantly on high alert in terms of an inflammatory response. There we go. For some reason, it's making me click twice to advance the slides. I apologize. So the things that we do know, obviously, we're not going to go through this ridiculously complicated slide in any great detail, but the things that we do know is that both skin psoriasis and psoriatic arthritis are inflammatory responses, as I discussed a few minutes ago. And this slide is just to sort of give you a very brief overview of some of the known players in the immune system, some of the different immune cell types, the so-called soldiers of the immune system, which are involved in this chronic immune attack. And represented in sort of the pink circles, most of them starting with IL, are a number of the cytokines which are known to be involved in the chronic inflammation of both skin psoriasis and psoriatic arthritis. And the idea basically is that, as I said a moment ago, the immune system is in high alert, it's in overdrive in patients who have skin psoriasis and psoriatic arthritis. And the way that the immune system talks to itself, summons up the soldiers and lets them know that there's some marching orders coming and we need to be on the attack and we need to be ready for battle, is through all of these different things that are mentioned in these pink circles. They're called interleukins. So IL-23, for example, near the top left is interleukin 23. And there are a number of other pro-inflammatory messages that the immune system sends off when it's in overdrive. Most of them are ILs, but there are a few others in there. You see TNF, tumor necrosis factor. Near the bottom center is rank ligand, or rank L. But the idea basically is, the reason I take some time to pause and point these out is that when we get into the treatment aspect of psoriatic arthritis, suddenly you're going to start seeing some things that look familiar, because we have some medications out there that are aimed at blocking these messages. And if we keep the pro-inflammatory message from being disseminated among the immune system players, we hope then that we can affect the severity of the disease by keeping down that amount of overactivation. The primary site then for psoriatic arthritis, which definitely sets it apart from some other types of arthritis, is the enthesis. And the enthesis is the location where a tendon approaches and blends into and becomes part of a bone. So in the top center here, I believe you can see my pointer. In the top center here, we have an enthesis at the insertion of the Achilles tendon in the back of the heel. And this is a very commonly affected area in psoriatic arthritis. You also can have effects in the joint lining, which is called the synovium. But one of the hallmarks of psoriatic arthritis, and one of the ways that it is different from other forms of arthritis, is its predilection to preferentially attack the enthesis. So who is at risk for getting psoriatic arthritis? If you have skin psoriasis, the severity of the disease does seem to be a risk factor, and particularly people who have pits or deformations of their fingernails seem to have likelihood to develop psoriatic arthritis. There is some contribution of family history, although having a family history does not doom a person. About 40% of people who get psoriatic arthritis do have a family history of psoriatic arthritis, but that means that 60% do not. And again, not every person who has a family history is going to necessarily develop the disease. We now understand that having excess adipose or fatty tissue increases the load on joints and may actually increase inflammation burden in the body. So being overweight or obese is a risk factor for psoriatic arthritis. And those who get affected at an earlier age by their skin psoriasis may perhaps be at higher risk for developing psoriatic arthritis. Other risk factors also include the use of alcohol, smoking, and there may be other environmental triggers which we do not yet have nailed down in any great detail. What are the symptoms? As I mentioned a few minutes ago, just 2 slides ago, the area where tendons and ligaments connect into bone, that so-called enthesis, is the primary site where psoriatic arthritis develops in most patients. And so swelling and tenderness in those locations can be the major symptom of psoriatic arthritis. That swelling and that tenderness, both by the physical swelling taking up space in and around the joint, and by the pain causing the patient to be less eager to move the joint, these two things result in stiffness and in reduced range of motion in the joints, and the stiffness in particular can be worse in the morning. We generally have a rule of thumb. There isn't a specific yes or no exact number of minutes, but generally speaking, we get concerned about a person who has tightness and stiffness in their joints that lasts more than 30 minutes in the morning. Low back pain and stiffness can also be a symptom. We call that axial disease, meaning that it's near the center of the body. And those can happen in any form of arthritis, but they tend to be quite common in psoriatic arthritis. Here you see some photographs of the nail changes I was referring to earlier, and these are common in skin psoriasis patients. They can include horizontal lines, changes in the shape of the nail, thickening of the nail, separation of the nail from the nail bed. That's seen in the upper left and in the upper right, especially, and again, I believe you can see my pointer, where the white part of the nail seems to be larger and extend further toward the finger than it should. Here's a good example. Here's a good example. Discoloration of the nail, crumbling of the nail, and this feature in particular is one that rheumatologists tend to look for, so-called nail pitting. These little dots are about the size of the tip of a ballpoint pen, so it almost looks like somebody took a ballpoint pen and just smashed it onto the fingernail and made these little dents. Ballpoint pen probably isn't strong enough to do that in real life, but that's kind of the size of the dent that you're looking at. And we often find that patients who have these pits will have psoriatic arthritis in those same fingers. So if some fingernails are pitted and some are not, oftentimes the pitted fingernails will be the ones affected by psoriatic arthritis, and the non-pitted ones may be spared. And in this particular case, although there isn't a lot of pitting, you can definitely see the swelling in the knuckle that's out by the fingernail. And we believe that because there is an enthesis here, where the tendon that is used to straighten out the finger is landing on and melding into the bone at the very tip of the finger at this location, that enthesial inflammation at this location, we believe, is responsible for both the swelling and tenderness of that joint, and in some patients, the pitting of the nail, which is directly adjacent to that joint. So these joints can be red, they can be warm to the touch, they can be tender to the touch. You can see sausage-like swelling, so-called dactylitis, where not just the knuckle, but the entire digit, the entire finger or the entire toe becomes swollen up like a sausage or like a cigar. Obviously, there can be pain in the heels where the Achilles tendon attaches. We saw a slide on that a bit ago. Similarly, there can be pain at the elbows where those tendons attach, pain in the feet. And inflammation can even extend in some patients into the eye and can cause redness and inflammation in the eye. That is called uveitis, because these layers of the eye that are involved are known collectively as the uvea. A couple of things that might make a person think that they're inflammatory arthritis, their arthritis that swells and hurts and is stiff in the morning and more than 30 minutes in the morning. The things that might make one think that maybe they have psoriatic arthritis, other than the fact that they also might have skin psoriasis, would be the presence of enthesitis, as we've already talked about, the swelling and tenderness where a tendon inserts on a bone. Dactylitis, the swelling of an entire digit, either a finger or a toe, in a sausage-like or cigar-like shape. Spondylitis, pain in the back and particularly in the low back, although it could be anywhere in the spine. And where we often think of many forms of inflammatory arthritis, particularly rheumatoid arthritis, as being polyarticular, involving 4 or more joints, and certainly psoriatic arthritis can do this, there are also some forms of psoriatic arthritis that are oligoarticular, meaning 4 or fewer joints are involved. And these joints in psoriatic arthritis can be more asymmetrical. In other words, other inflammatory forms of arthritis, such as rheumatoid, tend to, but are not guaranteed to, involve the body in a mirror-like distribution. If it's your pointer finger on one side, it'll be your pointer finger on the other. Psoriatic arthritis can be asymmetrical, where it might be the pointer finger on one hand and, for example, the ring finger on another. So here we see a photo of enthesitis. Here's that swelling of the Achilles tendon landing on and inserting into the heel bone, which is called the calcaneus. And up to half of people who have psoriatic arthritis will have at least one enthesial site affected. Most commonly, it's the Achilles tendon, but it also can be the bottom of the foot, particularly on the part of the heel that touches the floor, which is called plantar fasciitis. And also there are locations in the elbows, the knees, and the ribs where there are ligaments that attach, and these can also cause pain. Here's a good picture of dactylitis, a little bit in this ring finger and particularly in this fourth toe. A cigar-shaped swelling, pointy at both ends and puffy in the middle, but not just puffy at the joint alone, puffy in the entire digit. And again, between 1/3 and 1/2 of psoriatic arthritis patients will have this finding, dactylitis or sausage digits. Spondylitis, nearly half of people with psoriatic arthritis can have spondylitis, which is an inflammatory form of back pain. Now, back pain is very, very common. Not everybody who has back pain has spondylitis. Not everybody who has back pain has psoriatic arthritis. But here are some of the things that might make a person think that their back pain is inflammatory rather than mechanical. So going back to the idea of inflammation in the morning being worse in the morning and lasting at least 30 minutes or more in the morning. But then these other things here, these next three, are ones that might help you differentiate an inflammatory form of back pain from a mechanical form of back pain. So if you injure your back, you decide you're going to move your couch, or you decide you're going to move your bed to a different part of the room, and you kind of overdo it and you tweak your back, that's going to be a very sudden onset. Hopefully you're going to remember the event or the injury that caused that to start. Yeah, I was pushing my bed across the floor. I decided to lift the couch without anybody to help me and try and drag it from one side. In contrast, inflammatory back pain, people can't really tell us specifically what happened. It's been sort of just creeping up on them slowly over time, and they can't say, it was last Thursday when I lifted the couch that this happened. And where people who do injure themselves trying to move furniture, for example, would find that they would feel better when they rest that injured area, and worse if they try and use that injured area, inflammatory back pain generally is exactly the opposite. These people actually don't get better when they try to rest. And in fact, when they try to rest at night, they actually sometimes will have their worst pain. And sometimes it will force them to get up in the middle of the night, kind of the opposite of what you would expect from an injury type of pain. And they find that when they do get up, or particularly when they do a little bit of light, gentle exercise, they actually get better. So it seems to be back pain that doesn't make any sense in that respect with rest versus activity. So when should you see a rheumatologist? Anything that makes you think that your joint pain might be inflammatory would be a reason to get to see a rheumatologist. And basically, this is the list of things that we just went through. Prolonged morning stiffness, more than 30 minutes, stiffness, particularly of your low back or buttocks, that is paradoxically better instead of worse when you try to use the area that seems to be quote unquote injured. You're discovering that it's not really injured, it's inflamed. Areas that are swollen, areas that particularly are swollen where a tendon joins into a bone. So these enthesial regions like the elbows, like the knees, like especially the back of the heel. And dactylitis, the swelling of an entire digit, not just a joint itself. All those things would make you want to see a rheumatologist. And importantly, even one item off this list is probably enough that you would want to at least be looked at by a rheumatologist. You do not need to check off all 6 of these items. Even one of them is enough reason to have someone look at you. So why do we want people to come in and see us as quickly as possible? Now, of course, we're recording this webinar in the middle of the coronavirus pandemic, which is why I can't be with you in person. And of course, that's causing some delays in medical care kind of all over the world. But in a perfect world, we would love to have as little delay of diagnosis as possible. And one of the reasons for that is that delay of diagnosis is associated with worsening of long-term outcomes. So if a person's psoriatic arthritis is delayed by more than 6 months, before they discover that their symptoms are actually psoriatic arthritis, they get that formal diagnosis, they have an increased risk, or we mathematically call that the odds ratio, an increased risk of having some long-term outcomes that will be less favorable. So for example, the risk of having bony erosion is 4.5 times greater if there is a more than 6-month delay in diagnosis. The risk of having functional disability as reported by the patient is more than double or around double by having a greater than a 6-month delay in diagnosis. Patients are only about half as likely to remain medication-free in terms of advanced medicines like DMARDs or anti-TNF drugs if there's been more than a 6-month delay in diagnosis. So these are the reasons why we're very interested at the National Psoriasis Foundation in getting people identified as quickly as possible and getting them into medical care as quickly as possible, understanding that there are certain realities, particularly right now, with all the things that the world is going through, that are going to be fighting against us, but that doesn't mean we shouldn't fight back. So the reason why that diagnosis is often delayed is that there is no single test. There is no blood test that is the psoriatic test, that if it turns positive, we know you have psoriatic arthritis, they're done, end of story, easy. It just doesn't work that way, unfortunately. And that's another thing right now that the National Psoriasis Foundation is working at, and in fact is literally putting their money where their mouth is. The National Psoriasis Foundation right now is working on trying to recruit scientists who will give out research proposals in terms of trying to find that blood test or some other type of definitive test that would let us know with one simple assay or one simple blood or other type of medical test who has psoriatic arthritis and who doesn't. And hopefully the dream is that the National Psoriasis Foundation will one day be able to say with pride that due to the efforts of its members and its donors, it was the organization that gave the funding that found the test. Hopefully we'll be able to say that someday in the future. So without that single test, what do we do? How do we diagnose psoriatic arthritis? Long story short, it's a clinical diagnosis. A patient has psoriatic arthritis when I say they do, based on my simple clinical experience. But there are some guidelines that will help us. And those include giving patients who come into a dermatology office a questionnaire. And there have been a number of these questionnaires that have been proposed and are in clinical use. There are quite a number of them. I'm only going to cover one this evening. This is called the PEST, or the Psoriasis Epidemiology Screening Tool. And the idea is that we would hope that every patient who sees a dermatologist for their skin psoriasis will be given this questionnaire or one similar to it, not just once or twice, but literally every visit, because it can be sometimes up to 8 to 10 years after the skin disease develops, before the joint disease develops. So we need to keep asking and asking and asking, have you had swollen joints? Have you had a doctor tell you you have arthritis? Do you have those nails or pits or holes in the fingernails that we saw on an earlier slide? Have you had the heel pain, that enthesitis pain that we saw on an earlier slide, or a completely swollen toe or finger, again, that we saw in photos on an earlier slide? And patients who answer yes to these questions, hopefully then that will help the dermatologist realize, oh, this patient needs to be referred to a rheumatologist. Getting a little bit more into the nitty-gritty, what might happen at a rheumatology visit, these are the caspar criteria for psoriatic arthritis. Now, it's important to recognize that these were developed as research classification criteria, and their use as diagnostic criteria is a little bit controversial. But long story short, if you have inflammatory arthritis, which your physician or your rheumatologist can determine for you, and you've got either that in the form of arthritis, or in the form of enthesitis, or in the form of spondylitis, and you have at least 2 of the 3 features on this slide, we can say by the caspar criteria that you have psoriatic arthritis. And the reason why it says 2 or 3 is because the first one counts double. So if you have a current or a past history of psoriasis in you yourself, you already have 2 points. and you will only need one other thing off the list. It's a little bit tricky because the first item, if you don't personally have skin psoriasis, you can then go to the second item and see whether or not you have a family history of psoriasis. And if you do have a family history, you get 1 point for having a family history, and then you would need 2 items from the remainder of the list. Other things that might be looked at, although none of these things is the 100% just do this one test and you've got it tool. Blood tests looking for inflammation, such as the erythrocyte sedimentation or SED rate, the C-reactive protein or CRP. Blood counts might be done. All of these things basically looking for inflammation. Now, these things don't tell us what type of inflammation or what origin of inflammation a patient might have, but at least they would confirm for us that inflammation is present, and that is helpful. And then, of course, since the joints and the tendons and the entheses are the areas that are involved with this form of inflammatory arthritis, it would be good to be able to look at those areas non-invasively, and we can use advanced imaging beyond just x-rays like ultrasound or MRI or CAT scanning to look at those areas and see the inflammation as it's present. Regular x-ray also can be used to check the bony status, and there are some types of bone deformity and bone damage that regular x-ray can identify that would definitely support the diagnosis of psoriatic arthritis. But of course, x-ray's major weakness, also its strength, is that it makes the soft tissue invisible and lets the bones be seen. So when we're thinking about things like tendons and entheses, and these sorts of dactylitis, the swelling of an entire digit, that's much harder to see on x-ray, which is why these other forms of imaging, which will leave the soft tissue visible in the picture, are often favored. So we mentioned that early recognition, early treatment, early diagnosis helps to reduce the inflammation, and that's important because it is that inflammation that is causing joint damage in some patients over time. So the less exposure that the patient has based on getting recognized, getting diagnosed, getting treated, so that they spend less time inflamed, is known to help prevent that progressive joint damage. Lots and lots of treatments exist, and it's way beyond the scope of what we have time for this evening to try to discuss these different treatments in any individual aspect. We could spend the entire hour just picking one medication of those that we're going to go through this evening, and we could burn through the entire hour very easily just discussing any one medicine on these next couple of slides. But how do we choose among them? Well, there again, unfortunately, we don't have a blood test that tells us, oh, you need drug X. No, wait, you need drug Y. We just don't have that. So how we go about that is we look at these sorts of things that are on this slide. How severe is a person's arthritis? How fast is it progressing? What areas of the body is it affecting? Is this patient more of a dactylitis patient with a sausage digit? Is this patient more of an enthesitis patient with a swollen Achilles tendon? Is this patient more of a pure arthritis patient with a swollen knuckle? How badly is their life being affected? What is their functional status? I have some patients, for example, who are older, who are retired, who, especially right now, are shut in their houses, so they don't need as much functional improvement to be able to simply live their daily lives and keep fed and keep clean and keep healthy. I have other patients who are very active. I have one who immediately pops to mind who is a letter carrier for the U.S. Postal Service, and he earns his money and earns his living by being on his feet all day, every day, walking door to door to door to door to door, delivering mail. So he needs more control because he uses his body more on a day-to-day basis. We have to be watching for concomitant medical conditions or comorbidities, other factors in the patient's health. Are there certain medications that I might like to use which I really should be shying away from because of other medicines the patient may be taking or other health conditions that they may have? Some patients may have very strong preferences as to whether the medicine is given as a pill or whether it's given as a shot or whether it's given as an IV. How often is it taken? All these types of things. Unfortunately, we have to face the facts. The world is what the world is, especially in our country, where there are some issues with insurance sometimes, where insurance may dictate to us an order in which certain medicines might be tried. You can't try B or C until you've tried A. Patients' out-of-pocket cost is definitely a factor. You certainly can't feel that you're doing the patient a service if you're making their arthritis better by making them go bankrupt. That doesn't work. That is not the plan. And then there are, as was mentioned in the very, very beginning of this presentation, some treatment guidelines, which the National Psoriasis Foundation has worked on in conjunction with the American College of Rheumatology to develop in terms of what medicines might be preferred for what types of patients or what order those medicines could perhaps be tried in. And again, those guidelines are guidelines. They are not rules. They are not laws. It's important that everyone, and particularly insurance companies, must realize and acknowledge that guidelines are just that. They are guidelines. And for any particular guideline that we might talk about, it would be very easy. Any other physician who might be on the call this evening could probably, in less than 5 seconds, come up with a patient in their practice and say, no, but I have this patient who has this, this, and this, and therefore I can't do that and that. So these guidelines are meant for a general overall guidance for the population as a whole, recognizing that every patient needs to have their particular treatment tailored to them based on all the other things that we see on this slide. So just over a year ago, about almost a year and a half ago now, the American College of Rheumatology and the National Psoriasis Foundation, the ACR and the NPF, worked together and came up with a joint agreement of a guideline for the treatment of psoriatic arthritis. And that was published in the medical literature in November of 2018 in actually 3 different papers, 2 in the rheumatology medical journals, and 1 in the dermatology literature. All 3 of these papers were essentially identical copies of each other, published in 3 different journals so that we could get them into the hands of as many different physicians as possible. So whether you were a dermatologist subscribing to that journal, or whether you were a rheumatologist subscribing to one of the 2 major journals in that field, we could get these guidelines into your hands. So the key points there are that one might choose in some patients a TNF inhibitor, which is a biologic type medication, over oral therapies if the right type of patient presents themselves to the office. There may be some patients who may have milder disease or who do not want to take a TNF inhibitor. TNF inhibitors, by the nature of how they are made chemically, must be either injected or IV infused. They cannot be taken by pill form. So some patients may have issues with that and may want to try an oral therapy first. And for those patients, that may be reasonable. For patients whose disease is mild, an oral therapy might be reasonable. For patients whose skin disease is actually predominant over their joint disease, maybe they have psoriatic arthritis, but they also do have skin psoriasis, of course. And if their skin psoriasis is much worse and affecting their life more strongly than their joint disease, perhaps they would go to an IL-17 inhibitor rather than a TNF inhibitor. And if a patient is very concerned about dosing less frequently, having to take the medicine less often, the IL-12/23 inhibitors are taken less often. But again, we have to recognize that although all these points in the guideline are based on the scientific reality, the reality in the real world is that oftentimes the insurance company will not let a patient hop directly to an IL-17 or directly to an IL-12/23. Oftentimes the patient does need to go through other less costly therapies first before they're allowed to advance to these other treatments. We're hoping that someday, if we can get a test out on the market that will tell us what drug a patient is or is not likely to respond to, that perhaps then we would be able to convince the insurance companies to allow us to take medicines, quote unquote, out of order based on a patient's test results. But right now we don't have that. It's also important from the guideline to recognize that we want to use a treat to target strategy, where we want to identify a goal and a treatment plan and follow up our patients quarterly to get to that goal, and to assess at every visit whether or not that goal has been reached. Because we know that patients who are working toward a specific goal are doing better in the long run, both from the patient's perspective and from the physician's perspective. Like everything else in life, you know, if you contact a life coach, or a lot of us, I think, during the lockdown, when we're sheltering at home from this coronavirus pandemic that we're currently battling, you know, we're setting some goals. We want to come back out of isolation better than we went in. And anyone will tell you that if you're trying to get something done, if you're trying to get a new skill developed, or perhaps change profession when you get out of your isolation, you need to get toward that goal by making a number of interim target goals and be working toward a specific thing rather than just a general idea of, well, I want to accomplish this. And that turns out that it works in medicine just as it does in the rest of life. For patients who are obese, the guideline does definitely recommend weight loss. That, as I said earlier, will unload the joint and making it carry less weight. But also, we are beginning to understand more and more that obese patients actually may have more inflammatory burden than non-obese patients. So you actually might be reducing your inflammation by reducing your obesity. And patients who smoke, of course, should try their best and keep trying. And no matter how many times you fail, keep trying to stop smoking, because smoking, we believe, is a definite risk factor for having more severe disease and for having disease that is more difficult to treat. We know with quite a bit of certainty now that patients who continue to smoke are more likely to fail when we put them on whatever given medication. And those who do not smoke, or those who are ex-smokers, are more likely to succeed almost no matter what drug we give them. So here are just a little bit of data. I'm not going to go through this in a great amount of detail, but just to show you why we say this about tight control, about wanting to get a patient as good as we can get them, as quickly as we can practically get them there. So the orange bars on this graph are patients who were tightly controlled, and the blue bars on this graph are patients who were treated. They were treated, but they were treated without these specific frequent visits and frequent measurement of their disease status. And we see that in every instance, ACR 20 is American College of Rheumatology 20% improvement, ACR 50 is a 50% improvement, and ACR 70 is a 70% improvement in the patient's symptoms. And we see that patients are more likely to get 20% better, they're more likely to get 50% better, and they're more likely to get 70% better if they are tightly controlled versus if they are not tightly controlled in the blue bars. And these p-values here across the top are basically the mathematical way of reassuring ourselves that although we might look at this with our eye and say that 62 looks different from 45, you know, what if these numbers were 62 and 58? Would we be able to say those two bars are different or not different? This is the math. As long as this number is less than 0.05, and all of these numbers are less than 0.05, some of these numbers are way, way, way less than 0.05, we can mathematically say that what our eye tells us is the truth. These patients are different. This group is doing better than this group. So here are just a few of the treatment options, and these are presented not as individual drugs, but as broad categories. Oftentimes we do start with pain relievers and non-steroidal anti-inflammatories, things like ibuprofen or naproxen, and those can be good for pain relief, and they can have value throughout a patient's course of treatment. We can use traditional systemic medications. The main thing we think of there is methotrexate. In short term and for busting a flare, we can use corticosteroids, either by oral or by injectable treatment. We can use some targeted oral treatments, And there are, of course, biologics available. And then we don't want to forget that there are also some non-pharmacologic options, and we're going to discuss those very briefly as well. So NSAIDs, or non-steroidal anti-inflammatories, will reduce inflammation, pain, and stiffness, and by doing that, they will improve the range of motion. They're taken either by pills or applied to the skin. Some of them can be bought over the counter, some of them require a prescription, and some examples that I'm sure we've all heard of, or most of us have probably heard of many of, if not all of these, are listed here on the bottom of the slide. The important thing about the NSAIDs is that they don't really change the outcome of the disease. They improve symptoms, they improve comfort, and that's good, but they don't really change the outcome of the disease. For that, we need bigger medications, and the traditional systemics are among those, that they also limit joint damage in addition to just relieving symptoms. And some of the classical ones there are methotrexate, leflunomide, sulfasalazine. These are all pills, all taken by mouth, but they do require, because they are prescriptions and they do have more side effects, they do require some regular monitoring. Most patients do very, very well with very little trouble, but that doesn't mean you don't watch. You have to be watching these patients with regular blood testing to make sure that things are going well. Rapid relief of acute flare-ups can happen any patient, anytime, and oftentimes we will get over the hump there, get the patient back on an even keel by using corticosteroids, and those can be either in pill form or they can be done by direct injection into an affected joint. We have to be careful in psoriatic arthritis more so than in other forms of arthritis, because when patients come back down off their corticosteroids and they no longer have that steroid suppressing the inflammation in their body, their psoriasis can actually rebound as the inflammation comes back to its baseline level. Targeted oral treatments include Otezla, which is the brand name for apremilast, and Xeljanz, which is the brand name for tofacitinib. These work by blocking molecules in the body which are part of the pro-inflammatory chain of events. And by doing so, we break that chain. And these patients often do very well. Of course, not every patient does well on any particular drug. There are always patients who don't like or don't get the relief that they were hoping for from any drug that we name, but these are pills that can be done for psoriatic arthritis. Of course, they do have more side effects than non-prescription medications, but again, overall, they tend to be relatively well tolerated, and most patients do quite well on them. Moving beyond that, we have a whole family of biologics. Biologics are called biologics because they are grown rather than mixed up in a test tube. They fall into these 5 different categories: the TNF-alpha inhibitors, the IL-12/23 blocker. There are, and for all of these categories, there are more that are coming, but the ones that are currently on the market, there's one IL-12/23 blocker, there are 2 IL-17 blockers, there's a T-cell inhibitor, and there's an IL-23 agent on the market with 2 additional ones that are in clinical trials. You may recognize the names of these 2 as drugs that are already on the market for skin psoriasis, and we're hoping to learn soon whether or not they may also have value in the arthritic aspect of psoriatic arthritis. So patients who are placed on TNF-alpha inhibitors, we're going to devote a whole slide to this because these are often the drugs that are gone to first. Because number one, let's be honest, the insurance companies favor these drugs. The reason for that in many cases is simply because they are the oldest drugs. They are the ones that have been on the market the longest in terms of the biologics. Therefore, we have a lot of understanding. We have a lot of experience with these drugs. And they cause significant improvement in all of these things here: the enthesitis, the dactylitis, the patient's self-report of how well they are functioning on the drug versus before they were on the drug, the patient's report of how their quality of life has improved with the drug versus before they had it, and the improvement in the patient's perception of their fatigue. And then if we watch the patient's x-rays over time, we find that TNF-alpha inhibitors are good at inhibiting structural damage to the bone that can be caused by psoriatic arthritis. This is a trial of ixekizumab, which is not a TNF, but another biologic that was on the previous couple of slides. And what we see here again, as we saw on a previous slide, is that the colored bars, the 2 different doses of ixekizumab in the blue, 45 or 90 milligrams, are better than being on placebo, being on no drug at all for psoriatic arthritis. And that's shown in the gray bars. And that's true at 20% better, 50% better, and 70% better. And we don't have those P numbers written on the slide, but we have little stars that tell us that in all cases, that p-value is less than 0.01, which means mathematically we can say that our eye is telling us the truth, and the blue bars are different from the gray bars in each of these three categories. Here's another biologic, again, not a TNF inhibitor, but something that's often used later on. And here we're looking at the strength of these particular drugs tend to be in the resolution of dactylitis and in the resolution of enthesitis. We talked about that sausage digit, the swelling of an entire finger or toe, and the swelling where a tendon joins into a bone. And these are for complete resolution. And the likelihood of getting that complete resolution on the two higher doses of ixekizumab, the ones that actually ended up being FDA approved, versus the lower dose. So the reason that we don't see this little S-shaped symbol here is that mathematically, these two doses of ixekizumab were definitely better than placebo, different from placebo. These two doses in enthesitis were better than placebo, but these two bars, although they look different, the purple dose of ixekizumab, we couldn't mathematically say with certainty was any better than placebo. And that sort of, now you understand why the FDA has such rigorous rules about approving drugs. So this drug was, this dose was not FDA approved. This is the dose that the FDA approved. These two doses are the ones actually that got out onto the market and are commercially available because they have the data to back themselves up. Here is ixekizumab with its 20% improvement response in psoriatic arthritis. And we see the two approved doses of, the two frequencies of ixekizumab. And we also see on here adalimumab, which is a TNF inhibitor. So we're comparing ixekizumab versus adalimumab, which is sold on the market as Humira. And we see here now, previously when we saw all these bar graphs, we were only seeing one point in time. Now we see a line graph, and we see that the improvement versus placebo, versus being on no drug at all in the gray, is apparent right away at the first time point that gets measured, and it's sustained throughout the, in this case, 24 weeks, half a year of the trial. And then lastly, to close out with some non-pharmacologic options, not every patient responds to non-pharmacologic options, but there are some data out there which would suggest value from having patients undergo acupuncture. That one, of course, along with massage therapy, oftentimes you have difficulty getting insurance to pay for it. But if it's something that a patient can do without breaking the bank, acupuncture and massage therapy do have some value. They do have some evidence in their favor. Physical therapy often is covered by insurance and has evidence in its favor. Adaptive aids, like using a fat marker instead of a tiny little pencil to give the patient better grip, and many other adaptive aids exist. Technically, a cane would be an adaptive aid. Hopefully, a patient doesn't get to that point, but many of them often do. And for some patients, lifestyle changes. We already talked about obesity and smoking. So weight loss, smoking, exercise like Tai Chi, yoga, walking, swimming. We're not asking people to go and train for the Chicago Marathon, but just these simple, gentle, Tai Chi, very gentle form of exercise can be helpful for patients with many forms of arthritis, including psoriatic arthritis. And there are a lot of patients out there who do respond to stress. I have quite a number of patients who I can tell when they're having difficulty in their life just by whether or not their arthritis is active. Not everyone is like that. Some patients handle stress quite well in terms of their arthritis not being set off by stress, but there are many who do have that issue. And for them, it becomes important to do stress management as a form of therapy, as a form of treatment, to try to, obviously you can't delete stress from your life, but to try to manage your stress so that it doesn't trigger your arthritis. So a couple of closing comments, and then we'll have just a few minutes for questions. We talked about how early diagnosis is important and how we don't want patients to delay. Try to get in to your primary care physician to get that referral or to get to your dermatologist to get that referral so that we can get working on your psoriatic arthritis. We want to treat patients to a goal and find the right treatment for that patient rather than just treating them every patient the same. And it's important that you do more of what you've done tonight. Get more information, learn more about your disease. The National Psoriasis Foundation has many excellent resources for that. And you can certainly go to psoriasis.org and they can guide you through a lot of that stuff. So without burning up too much more of our very limited question time, because I'm a babbler and I talked and talked and talked, I'll turn it back over to the moderator for the question and answer section. Thanks for your attention this evening.
Well, thank you, Dr. Mandelin, for your presentation. That was very informative about the symptoms, features, and treatments. So we do have a few questions. The first is, do the guidelines for monitoring bone health change if steroids are used intermittently in times of disease flare?
So the guidelines for monitoring bone health are separate from the guidelines for monitoring psoriatic arthritis as a whole. The short answer is that steroid exposure does count and does figure in to bone health. But we're talking about sort of two different things when we talk about bone health. One issue is, are the bones being damaged by the inflammatory arthritis? And one is, are the bones being damaged by the overuse of steroids? And the damage that can happen from the inflammatory arthritis tends to happen in the locations where the inflammation was the worst. And the damage that tends to happen from medication use, particularly steroids, although there are some others that have been implicated, happens all over the body. And that's the so-called osteoporosis, or the lesser form osteopenia. And they're measured in different ways, they're tracked in different ways, but the short answer to the question is that if a person is on steroids, and particularly if they're on steroids chronically, and particularly if they're on steroids at higher doses, then when we monitor not just the joint by joint areas that have been inflamed, but the whole body using bone density scanning, often called DEXA scanning, those raw numbers of how dense or how non-dense is the bone get put into a risk calculation that lets us know how bad is this person's risk for developing a bone fracture with only a minimal trauma. For example, just slipping and falling, not being on a step stool, not being down the stairs, but standing on their kitchen floor or standing in their own tub and slipping and falling. Is this person at high risk or standard risk for breaking a bone in a fall that should not have resulted in a broken bone? If you are a chronic steroid user, that fact of your chronic steroid use gets figured into that risk calculation and helps us to know whether or not a treatment is needed to try to intervene and mitigate that risk.
Okay, thank you. Here's another question. Is the potential weight loss reported with the use of Otezla known to be fat or muscle? I'm concerned about muscle loss I have experienced with age.
To my knowledge, the only thing that was reported was the reduction in total body mass. I do not believe, to my knowledge, that the researchers who worked on Otezla looked at basically a body fat content to determine whether the weight loss was muscle or whether it was fat.
Okay. All right. And do you know, will blood glucose be affected by treatments for psoriatic arthritis?
The main treatment that would affect blood glucose would be systemic steroids, corticosteroids. Those are clearly known to have an effect on blood glucose. The other treatments are not famous for that cause. Obviously, people are not machines. We're not all carbon copies of each other, and different people will respond to different medications differently. That's one of the things that keeps my job interesting. But basically speaking, we are very concerned about sugar levels, particularly in a diabetic, if we are using steroids, and we are less concerned about sugar levels, much less concerned with any medication other than steroids.
Okay, great. And another question. So I was diagnosed at age 62 with psoriatic arthritis, but I do not have psoriasis. I've been weaned off methotrexate and now on Enbrel for 9 months. This medication is very expensive. Is it possible to take this medication every other week, or are there any other options to help patients with a monetary gap?
Okay, so the question is, can biologics such as Enbrel be stretched out and taken less often? We are just now beginning to get the very, very first results from the very earliest research asking this question. And we don't have a solid answer yet, but the early research is beginning to suggest that there may be some patients who are very, very well controlled who may be able to take their biologic less often. That will not succeed for every patient, and at this point we are not yet recommending that in general, because we do not yet have the level of detail that we need to be able to tell a patient you're at high risk for doing poorly if you go to every other week versus you are at low risk for doing poorly if you go to every other week. We are just beginning to get that information, and hopefully we'll have more on that as things go forward. The other thing we have to worry about with that is if patients take their medicine less often than the label or the original FDA approval would recommend, that up and down, that ebb and flow, not keeping a constant level of medication in the body, there is also some concern that that may allow the body to develop, for lack of a better word, an immunity against the medicine, in which case the medicine then stops working. And if that happens, it stops working forever for that patient, and you're forced to change to a different medication entirely. We, again, don't know who's at high risk for that, who's at low risk for that. That is another factor that we need to understand before we can start telling people, yes, it is safe for you to take your medication less often than indicated. In terms of other things that might help patients with the high cost of their medication, the number one thing is to make sure that you're connected with the manufacturer of that medication. Every manufacturer has a patient assistance program. They have a vested interest. They want to keep you as a customer, because if they lose customers, they lose money. So they would rather help you find ways to pay for your medication and keep you as one of their customers. And you might say that that is maybe a little bit self-serving on their part, but hey, if they're going to invest the money and the effort and the time to help you, then certainly contact the manufacturer of your medication and ask about income-sensitive pricing. Ask about other types of assistance that may be available. There are charitable foundations which can help patients pay for their medications. So yeah, long story short, contact the manufacturer, and most of these manufacturers will be more than happy to look at your level of need and assist you in paying for your medication. And if that doesn't work, then it's important that you contact your prescribing physician and let them know that you're having difficulty paying for your medication, because although it's not the best option to switch a patient from one drug to another, I'd rather have a patient on a drug they can pay for than have them not on a drug because of the cost.
Okay, excellent. I know a lot of patients are in that dilemma, particularly right now. One last question has to do with NSAIDs, such as ibuprofen. Can ibuprofen adversely affect the gut biome?
We know that ibuprofen certainly is harsh on the gut, and there are some patients who clearly do not tolerate ibuprofen or whatever nonsteroidal that you mention. Some of those we discussed in this evening's talk are purpose-built. Some of the prescription ones are purpose-built to be gentler on the stomach, but even that isn't perfect. Not every patient gets that benefit. We don't specifically know, to my knowledge, whether that harshness on the gut is from a change in the biome. It's more strongly suspected that the issue with how this works in the inflammatory milieu of the gut may be more important. We do know that these nonsteroidal medications, by the way that they work, are they on the one hand are reducing inflammation, but on the other hand they are also deprotecting the gut. They are turning off the inflammation, but at the same time they are also turning off some of the gut's natural protective ability, and that's an unintended effect of some of the NSAIDs. And again, that's why some of the prescription NSAIDs that were listed in tonight's talk were specifically developed so that they would have the one effect, the one that we want, the reduction of inflammation, and they would minimize the other effect, the deprotection of the gut, which we'd prefer not to have.
Okay, great answer. Someone had asked about the website data for citizen scientists. It's up now. If you can quickly grab that, I will move on to another slide. And before we do that, definitely wanted to thank Dr. Mandelin for taking time to answer the questions. We're a bit over on our time, but we appreciate your help. And I know everyone appreciates your taking the time to answer their questions specifically.
Yeah, thank you for having me. We got started about 5 minutes late, so I think we're pretty decent on time. And definitely, I want to turn it back over to you because I know there's just a few more slides wrapping up, and some of this actually may have some value to the audience, particularly if you had a question that you couldn't figure out the website, couldn't get it entered into the computer, or just were too shy to ask your question tonight. That happens. It's okay. Then certainly I think a lot of these things you're about to talk about from the National Psoriasis Foundation will be great resources for people who may still have some questions.
Absolutely. Well, thank you, Dr. Mandelin, for that support, and we appreciate all that you do. So May is Psoriatic Arthritis Action Month. You can continue to learn more about psoriatic arthritis from screening to treatment options. We have a short screening test that you can take if you go to the website that's listed here. You can request a free PSA e-kit, which includes information about mobility, stretches for psoriatic arthritis, and tips for being physically active with psoriatic arthritis. You can access the activities at psoriasis.org/PSA-action-month. You can also support the NPF's research efforts to identify a diagnostic tool for psoriatic arthritis. We are currently funding 6 PSA diagnostic test grants. And as Dr. Mandelin mentioned, our hope is to prevent the development of long-term joint damage by developing this test. If you'd like to hear more information, we do have podcasts focusing on psoriatic arthritis this month. You can listen through Apple Podcasts, Google Play, Spotify, iHeartRadio, or a feed service of your choice. You can access podcasts at the website listed here. Upcoming during May, you can catch an excellent podcast about fatigue, musculoskeletal symptoms, and one about diagnosing psoriatic arthritis later in the month. Dr. Mandelin also has an excellent podcast, number 21, talking about the difference between psoriatic arthritis, osteoarthritis, rheumatoid arthritis, and gout. So if you have questions about how do you know the difference, that's an excellent podcast to catch. If you have more questions and need additional help in finding a physician like a rheumatologist or accessing other treatments, please get in touch with our Patient Navigation Center. You can call 1-800-723-9166, option 1, or you can type in a question at psoriasis.org/navigation center. Once you leave today's webinar, you'll receive a survey to provide feedback about the presentation. Tell us what you think. We really value and appreciate your comments. Again, a quick thank you to our sponsors for their support of tonight's program: AbbVie, Amgen, Bristol Myers Squibb, Lilly, Novartis, and Pfizer. You can access all of our webcast archives at psoriasis.org/webcasts. and this presentation will be loaded in about a week. We appreciate your attendance, and we hope you'll join us again. Thank you.